So I'm sure that everybody in the room is very, very excited at the opportunity to have a talk all about radiation protection for the next 15 or 20 minutes. And I'm afraid to say that I'm going to take you rather back to basics. So just really two main reasons really why we have to think about radiation protection. Obviously, the most important thing is we need to make sure that we protect ourselves and anybody else from the risks of ionizing radiation, but also very importantly to comply with law, and that will vary from country to country quite how the radiation protection legislation sets out the requirements. And with this being the first intra-operative radiotherapy high energy unit in the UK, it posed some interesting questions that we didn't necessarily have sort of direct answers to. So again, going back to basics, so the radiation hazards associated with the Mobitron. So the Mobitron is delivering radiotherapy via electrons. So we've got negatively charged particles which can cause ionization. So they can either directly interact with DNA and damage it, or more commonly what happens is they interact with water molecules in the body, they create free radicals, and those free radicals damage DNA. And that's what you're hoping to achieve in order to deliver a radiotherapeutic impact with it. So at the end of those processes, there are two different tissue effects that can happen. Either you can have cellular death, and at a very high dose of radiation, that would be a direct death. More commonly, it's just that your cells lose their reproductive capacity. But you can, at lower doses, cause cellular transformation, which can result in cancer induction from that ionizing radiation. So DNA damage takes place in three things that can happen. So the cell can sort of repair itself and go on as a viable cell. The cell can become unviable, and obviously this is what we're hoping is going to happen for the sorry, is this a pointer somewhere? We're hoping for the cancer cells that they're going to become unviable, but what can happen is that you can have a distortion of cells and actually you can induce cancer. So what we're worried about, from my perception, from a radiation protection concept, is making sure we minimise the risk of people who are occupationally exposed to radiation of getting cancer. So the graphs that you can see here, the top one is looking at the probability of survival of a cell post-irradiation against the dose of radiation you deliver. So as you'd all expect, giving intraoperative radiotherapy, if you give a higher dose of radiation, you have less probability a cell will survive. But down at the lower end of the dose range, what we can see is that the probability of cell transformation rapidly increases. And this follows what we call a linear no threshold model. So even a very small dose of radiation has a small risk of transforming DNA, which can ultimately result in cancer. So we need to make sure that we keep doses as low as we reasonably can for occupationally exposed staff, because although the risk associated with ionizing radiation is low, if you give any radiation, the risk isn't zero. So you've seen the depth dose curves a few times. So the reason we use electrons is because we can have this controlled deposition of energy in tissue. And as we've said, for the Mobitron, we have three different energies which we can use to deliver the radiation at different depths. And we just had a conversation about bolus. So if you put bolus in front of the tumour, you can use that to also control exactly where you deposit the energy. So good news, it deposits the energy in a very controlled way. But if you look at the curves, what you will see is all of them have this continuity and this sort of deeply penetrating radiation. So the electrons themselves are absorbed over quite a short distance, but they undergo something called Bremsstrahlung. So I suspect everyone in the room did physics O-level and will remember, how do you create X-rays? You accelerate electrons at a target, they slow down, you get braking radiation or Bremsstrahlung, and you generate X-rays. So that's what's happening with our electrons that we're trying to use for therapy. We're generating some very high energy X-rays, which are very penetrating, and so they can cause us a hazard associated with that, with the unit. So just to mention sort of two different units that you'll have heard mentioned. So we've all been talking about how we prescribe radiation dose. So we describe the amount of energy per unit mass we want to be delivered to the tumour, and we describe that as grey. In radiation protection, we use another concept. So we take the absorbed dose, the amount of radiation that we're delivering, and we multiply it by some factors that recognise how radiation damaging different types of radiation are and what's the impact of radiation, different radiosensitivities of tissue. And we've referred to that as effective dose, and it has the unit of the sievert. So you'll hear us talking about grey to prescribed dose, and in a radiation protection concept, if any of you have got your issued monitor to measure your radiation dose, were you to ask what your dose was, it would come back to you as a dose in sieverts, which gives some indication of the risk. So the International Commission of Radiation Protection over many years have done lots of radiobiological studies, lots of epidemiological studies of irradiated populations. So it includes people like the survivors from Hiroshima and Nagasaki, occupationally exposed individuals, people exposed in medical experimentation. And what they found is at that low dose end of the curve, so not at the therapeutic end, but at the very low dose end of the curve, what they found is that per sievert of dose you give, the probability of inducing a fatal cancer is 5 times 10 to the minus 2. And so that translates to, if someone was to receive 20 millisieverts of dose, then they would have a 1 in 1,000 lifetime risk of developing a fatal cancer because of that dose. So 1 in 1,000 as a risk from an occupational point of view is generally perceived to be kind of acceptable. So if you're trying to design a factory to minimise the risk of someone dying in a mechanical accident, or you're looking at other kind of occupational hazards, 1 in 1,000 is generally considered acceptable. But that assumes someone has applied for the job and understands the risks associated with it. So our legislation says that a radiation worker can receive up to 20 millisieverts within a year. So because of the hazards associated with radiation, just internationally, there's a general radiation protection framework that we all work to, which has this sort of basic 3-word mantra, justification. So you only use ionizing radiation if you've done a risk-benefit analysis and you've absolutely convinced yourself that it is the right thing to do. Optimization, so for the treatment, that's about targeting it, using the small applicator, Alex, rather than the big one, so that you're only targeting the tumour cells. And in a radiation protection point of view, it's about keeping your doses as low as reasonably achievable. And then dose limitation, so making sure we stay within those legal dose limits to keep people at a level of risk which is perceived to be acceptable. And so in the UK, the way we meet that basic radiation protection framework is through 2 statutory instruments. So we are legally obliged to make sure, if we're using ionizing radiation, that we meet the requirements of both of these sets of regulations. So the Irma regulations are really focused on the protection of the patients, and they basically say, make sure you've done a risk analysis, make sure that you deliver the treatment with correct equipment by staff who are trained to the correct patient, and as much as you can, reduce the probability of an accident. So that's in a nutshell what that very long and very dry document tells us. The ionizing radiation regulations, which are more the focus when you're setting up the service, are about the protection of staff and the general public. And again, they require, as soon as you have a source of ionizing radiation, that you do a radiation risk assessment, that you then make sure you ensure that your facility is designed to keep doses as low as reasonably achievable and within dose limits. And then they set out requirements for when you need to designate your area as controlled. And when you control an area, you're then required to make sure you manage who goes in and out. People who go in and out, you can evidence what training that they've had, and that you have an appropriate management structure for that risk. So I think everybody kind of rolls their eyes to the heavens a bit as we come back to this legislation, but we are very closely scrutinised by the Health and Safety Executive on how we comply with this. They have approved codes of practice which set out a lot of details of how they expect us to meet those requirements, and then there are sort of professional guidance, which is what we try to follow in order to sort of keep people safe. So in terms of dose limitation, the table at the top here sets out what is included in the regulation, and it basically said, so radiation employees, so again those are people who are recognised radiation workers, may receive up to 20 millisieverts per year of dose, recognising that it's okay for them to have a sort of 1 in 1,000 risk of cancer induction as a result of it. But they say actually members of the public, trainees, so staff under 18, and also the fetus of a pregnant woman which is treated as a member of the public shouldn't receive more than 1 millisievert of dose, and recognising you may receive that dose from multiple different sources, actually we're required to keep those doses below 300 microsieverts per year. So it's a very, very low dose, it's a very low risk, but this is what our approved code of practice tells us we should do. So because of the diverse range of people we've got coming in and out of theatres, we would not be able to evidence at the level the Health and Safety Executive require us that all the people in that environment are radiation workers. And therefore we work to, with our radiation protection measures to make sure that other than the staff specifically associated with delivery of treatment, we keep these doses below the 300 microsievert limit. And then there are a few other things which come into the approved code of practice. And again, anyone who is specifically interested in the radiation protection can come and talk to me about these numbers. But to say there are requirements that we look at the time average dose rate over a working day, and also that we look at the instantaneous dose rate, so the dose rate time averaged over just 1 minute. And these can be quite challenging when you look at these against Mobitron in a standard operating theatre. So there is some published data which has been published by Kretchetov et al. And it describes what the leakage and scatter distribution of radiation looks like around a Mobitron unit. So if we had literally no control measures in place, which we wouldn't do, if you were able to walk into the room while the beam was irradiating a patient and stand kind of 10 centimetres away from the unit, it would take you about 45 seconds to achieve the annual dose limit for a general member of the public. So clearly we have to make sure that you're not able to do that. So we work with 3 basic principles in radiation protection. It's all very simple stuff. We use time, we use distance, and we use shielding as our general principle. So in this case with Mobitron, we start at the top and we work with distance. So we try and work out with our facility, how can we maximise the distance that anyone is from the unit at the point that we turn it on and we irradiate. We can potentially apply shielding or take advantage at least of shielding which is already existing. And then finally, we can look at how much time people are exposed for by a radiation facility. So coming down to the sort of practicalities in Southampton, so we have our Mobitron unit in what we call Theatre T, and this shows a drawing of the unit. I'm sorry, is this a laser?
There's a button, the second one on the right.
Pointer. Oh yeah, thank you. So what you can see is, so this is the outside of the building. So this is ideal from our point of view. There's going to be no exposure. We have to put in permits for work for the window cleaners to make sure that they don't end up coming up there at the point that we're doing surgery, but hopefully they're not doing that anyway. And we're able to control access through this door. We have the operating control at the back of the anaesthetics room. We can stop anyone coming through this layup room. We don't have any access into the scrub room. So basically, we've got quite a nice contained area where we can say, right, while we're delivering the radiation, no one can enter this point. The bits that we can't really control is whether anyone is in the theatre next door, because we never know quite what time of day we're going to be ready to deliver that treatment. And so we can't stop someone being over here at the time of treatment. We need to have people in the anaesthetics room to deliver the treatment. And I will come on to it, but we decided we could control the recovery area. And that's why we decided to put the unit down in this corner, because it gives us the best control of where the radiation doses are going to be around the theatre. So then we're able to take that information which has been published about what the expected dose rates are around the unit and using some basic physics to allow for the distance, and in the case of the floor above and the floor below, taking account of the thickness of concrete which is in the floor and the ceiling, we're then able to calculate what the doses are at each of the areas that are occupied. So this is the data that's been published. So this just shows you all the different orientations of the unit. So this gives me an indication of what radiation dose is coming out around the beam blocker for the unit, coming out from the sides of the unit. And again, we've seen the first plane. So the basic method then is work out how far away you can push people without impacting too much on the basic function of the unit, calculate the dose rates in those occupied areas, making use of the published data, and then you've got the information that you need. Just a few observations about the use of the data. So that data does have some assumptions within it. So it does assume the distribution that there is the equivalent of at least 6 centimetres of gypsum between the point of measurement and the point of your radiation beam. And actually in a standard operating theatre that often isn't the case. So your radiation protection advisors do need to give that some consideration. The data is the average of all energies, and actually you see quite big variations with different energies. So you see higher dose rates on the floor below at the high energy, and you see higher dose rates for the lower energy for the sort of adjacent areas lateral to the theatre. And also the data is all designed with the unit pointing directly down, but as you will see, we've got lots of degrees of freedom of where we can move the units. You just have to have a think about what direction is the beam going to point and what impact might that have on people working below. So once you know those dose rates, you basically have two choices. So either you can work out what additional shielding you need in order to allow you to deliver as much radiation as you could possibly want to deliver in that theatre. But bear in mind, if I could count on, or I couldn't count on my hands how many times the state say, yeah, just need a sheet of Cat5 lead, don't we? Because they're all experts in radiation protection because they're all used to putting shielding into theatres to have a KV imaging X-ray unit in the theatre. And you have to keep going back to them saying, no, it's a little bit higher the energy than that. So where you're used to maybe, 1 millimetre of lead, if you want to have the equivalent shielding effect, maybe you're talking about 5 centimetres. And then they will go a bit pale and start worrying about the foundations of the building and whether it's going to fall down if they try to do this. So I'm not suggesting you need 40 centimetre thick walls all around your building, but you do need to add a slightly more appreciable level of shielding than you do have to for a sort of general protection measure. The alternative, and what we've done at the moment for Theatre T, is you work out what is the maximum permissible workload in the theatre, and that then will potentially constrain how many patients you're able to put through in a day and in a year. You need to make sure that when you're doing your radiation protection calculations, you don't just account for the dose you're going to give to the patients. You also need to think about that quality control that Adley was talking about earlier. And also, as Adley's mentioned, don't forget, even if you have a theatre that you're happy about the dose constraints you're going to work with, you are going to need access to a shielded vault to initially undertake the commissioning of your machine and definitely to do the comprehensive, at least annual maintenance that you have to do on the equipment. And that needs to be accessible because driving the Mobitron, as Adley says, can be quite arduous. So in terms of sort of how we meet the dose constraints in Southampton, so first of all, we chose the best positioning for our unit. And once we decided the best positioning, we thought we'd make it really easy for everybody to know exactly where that is. So we've got a different colour bit of lino to make sure that when they use the Mobitron, they make sure it is in the right spot. Because if they move it closer to the other walls, they risk irradiating staff in the rooms adjacent. This is the recovery area. So when we did dose rate measurements in the recovery area, we did find that they were higher than were really acceptable. So what we've now done is we've had this special curtain customised for that bay. And just for the duration of the time we're actually irradiating with the Mobitron, we declare that a controlled area. So nobody is allowed to access that recovery bay. And obviously there is no patient on the inside of that curtained area. At the moment, we operate with a constraint where we allow a maximum of 1 QA and treatment per day and up to 52 patients within a year. So basically, 1 day a week, we are allowed to do intra-operative radiotherapy. And for now, we control access to Theatre T in the recovery bay while we're delivering treatment. And we additionally don't allow people into Theatre S while we're doing the quality control in the morning. So we've been able to comply with most of the guidelines. At the point that we first went clinical with this, our approved code of practice did say that if people untrained in radiation were going to be able to access an area, the instantaneous dose rates, time averaged over 1 minute, must be under 7.5 microsieverts per hour. And we were not nearly able to achieve that limit. We tried to bring ourselves closer to it, so Mobitron's standard operation unit would operate at 10 gray per minute, but we have ours at 3 gray per minute, so we just bring the instantaneous dose rate back by a power of 3. And in the more recent guidance that's come out for the UK, we are now allowed up to 100 microsieverts per hour as an instantaneous dose rate, so we now feel we're sort of slightly more compliant from a legal point of view. So again, Adley's already mentioned QA gets done before the each treatment, and again we don't allow anyone into the theatre around us at that point, so typically that's done either the night before or first thing in the morning by the physics team. And then just sort of a few extra basic safety measures which again are all legally required. So internationally recognised radiation signage. So for Theatre S, we just have these right-hand temporary signs which are stuck up over the doors and then collected and taken down. We have more permanent signage in Theatre T, which is interfaced to the treatment unit, so comes on when the power comes on with the treatment unit. A few additional safety features. So we have the lovely red button, which you have to remind your anaesthetists and surgeons not to put their coffee next to switch your machine off. But again, there is only a risk associated with radiation as long as there is power. So our legal framework requires that we have a quick, easy mechanism to cut the power on that unit should anything go wrong. And we also have what we call room doors interlocks. So there's a chain of interlocks on the theatre that if somebody did accidentally open one of the doors during the irradiation, it would switch the machine off. And again, that's required under our approved code of practice for radiation protection in the UK. So after we'd put all those protection measures in, from a radiation protection advisor point of view, the first thing we want to do is a comprehensive radiation dose survey to have a look at what those instantaneous dose rates are in all of the areas around us. And then to follow that up, we have got environmental monitors and we have staff wearing their personal dose meters so that we can make sure that we do keep people within safe limits. So when we first went live with this, as I say, the UK approved code of practice required that the instantaneous dose rates were below 7.5 microsieverts per hour. We knew we weren't going to get down to that level, but we basically went out to tender targeting 30 as a maximum. And what we initially found was that the office below, so this was the office on E-level, where there would be 100% occupancy, we had no way of controlling access to that while we were doing treatment, had 65 microsieverts per hour. And so Intra-op have helped us out, and Adley mentioned our slightly heavy auxiliary shield. So we've got this additional lead shield added on, and that's reduced this value down to a value of about 30 microsieverts per hour in that office below now. So, so from a physics and a radiation protection point of view, it's quite a cultural shift. We're all used to this 7.5 microsieverts per hour, and it feels very uncomfortable as you wander around with your dose rate, measuring what to us are very high dose rates. But what we have done is, with our environmental monitors and our personal dose meters, we have confirmed that we're not meeting the best practice time average dose constraints in any of the areas. And I am cool and hip, Alex, so I have got a smiley at the end of my presentation. Thank you, that's all I've got to say.